It's time to call the meeting to order. And there is a quorum, so we can go with it. And the first item on the agenda is the consent agenda. All the following items which concern reports and items of routine nature normally approved at AHA meetings will be approved by one vote unless any trustee desires to have a separate vote on any one of these items. The consent agenda consists of the discussion, consideration, and action on the following items. A, minutes of the regular trustees meeting January 28th, 25. B, finance committee meeting February 18th, 25. And C, check report January 9th and 2, February 8th, 25.
I move to approve the consent agenda as listed.
Second. Motion by Dr. Simon, second by Mr. Bowman. All those in favor of the motion, signify by saying aye.
Let's do that call for the roll.
That's right. Forgot our other. Yes.
Martin,
Yes.
Bowman,
Yes.
Simon,
Yes.
Mossberg,
Yes.
Brown.
Yes. And now we got that done. Move on to CEO's report.
All right. So we've been pretty busy. Clinics have remained busy. Hayla Nasser has taken a job at the Career Tech and is leaving us actually Thursday, which we really hate. Hayla's done a fantastic job for Steve. But she has been training her replacement, which is Lainey Neal. Lainey joined us last week and has been getting all the tips and tricks from Hayla. So Lainey Neal will be Steve Madrid's new nurse. Regina has been working with Darlene Bainbridge on our SQSS software, getting things into place. She was here probably, I don't know, a couple weeks ago. Coco's been really busy in radiology and lab. They both had their inspections over the last few days, and both areas, radiology and lab, did a great job, and just a couple of things that they'll have to work on, but very proud of both of those departments, how they performed. And they have been busy as well with all the flu and COVID and everything going around. Surgery's busy. Dr. Guerra is the newest one to come on. So he and Dr. Roberts, Dr. Roberts is here 1 week for general surgery. Dr. Guerra is here the next week. Doing a great job. It was funny. I don't know who the gentleman was, but Kelly and I was meeting in my office today, and we could hear somebody bragging out in the hall about our services, and somebody was out there telling Regina how much they enjoyed having their service here. It was one of the surgeon services, and so that was good to hear. It's good to keep it local. People really enjoy not having to spend a whole day traveling, you know, and coming home after you've had surgery and getting home late. So we are thankful to be able to provide those services for people. Registration at front collections, maybe a little bit down for this time of year. We were looking into what might be causing that. We have signed up to be provider for the Zero Card and Health Choice Select, maybe causing some of that. Typically in January is when deductibles start over, and usually we'll see an increase in upfront collections, so we're taking a look at that to see how that's affecting our reimbursement, impacting that. Reese has been busy lately working with wrapping up e-clinicals, trying to get the information out of e-clinicals stored so that we can access that and get off of paying anything to e-clinicals monthly. He's also working on, what was another?
6.0.
6.0, and then we're looking at trying to operationalize some of our mammography stuff that they're having to do manually. He's working on that. So The IT risk looks good, looks like employees are doing a good job with no E4, they're in the green, which means they're paying attention to any kind of phishing attacks or threats that we all get hammered with daily. Other than that, we continue to move forward with trying to wrap up our True Bridge agreement. Still have not got a final word from them on letting us out of the contract early. With that said, all in all, if we do have to run that contract out, that ends in June. We have identified a new company a company actually that we currently work with that would take that over, and we have high hopes that they will provide a better service for a billing company. So more to come on that. That's all I have. Anybody have any questions for me?
I might say that any comments I've received since the last time we met have been well received for the hospital, the staff, and how they were treated here at this facility.
Thank you. I appreciate that. I will pass that on. It's always nice to hear. It's nice to hear. That's why I have my desk at the front door. Now, a lot of times my door is shut, just simply, I put that on my list today for an airlock up there. If we can control the air in the, the front lobby, that door opening and closing, it sucks all the warm air out. But a gentleman did step into my office last week, and it was refreshing to hear him say, he said, I don't hear much negative about the hospital anymore. And he said, that's really good. He said, I can tell you guys are doing a good job. And that is so nice to hear, from somebody who's been here for a long time. So anyway, thank you for saying that, Greg.
Any other questions? We need accept the motion to approve or disapprove the Shared Medical Center written report for February 20.
I move to approve the Share Medical Center written report for February 2025.
Motion by Dr. Simon,
Second.
second by Mr. Bowman. Call the roll.
Bowman,
Yes.
Simon,
Yes.
Mossberg,
Yes.
Brown,
Yes.
Martin.
Yes.
CFO's report.
So I want to start with just a couple of things before I get into the financials, but we did meet last week, and part of our meeting was a presentation from Train. I think we probably communicated, or it had at least been in previous minutes of the Finance Committee, that we've been doing a kind of an energy assessment and an equipment assessment of our mechanical system in the hospital. The Train came in and did the assessment that basically put kind of trackers in various locations of the hospital to track air quality, temperature, humidity, those types of things. And those were in the hospital for a few weeks, maybe a month, maybe a little more than a month. But anyway, they presented the findings from their report. I will just point out a few things, not the whole, they gave like a 40-minute presentation. I'm not going to do 40 minutes again, Connor. I figured that. Basically, their utility analysis brought us in that per square foot, we're spending about $3 a square foot to provide our heating and cooling and water and all our utilities for our building, which is not bad. It's better than our peer average in our region. But they cautioned us to say, but it doesn't mean necessarily that you're that efficient as much as our utility costs are maybe a little bit lower here in our immediate area than they are in the rest of the region. With that said, there's room for improvement in our efficiencies. They did do an equipment analysis, and 61% of our mechanical system in the hospital is operating beyond its useful life, or life expectancy, and that's according to nationwide standards for heating and air equipment lifespan. So we've got some equipment that we really need to look at, upgrading and bringing up to a more reliable standard. Most of the issue is that the age of our equipment is such that some of the things we can't find parts for, and if we can find parts, there may not be the skilled labor out there anymore that know how to work on our particular equipment. So that's an issue. Our control system is an issue, being that we don't have a single control system. We've got like 3 different control systems that we use to control our HVAC. And if we go down with one of these systems, it really limits our ability to take care of patients. So the need to address this it's a pretty good need, that we need to be making plans to how we're going to take care of those pieces of our hospital. The parts that don't actually provide any patient care, but if you don't have them, the rest of the stuff doesn't matter. They did give us a preliminary budget of just under $2 million. So, we'll cut the check tomorrow and get it all taken care of. You guys know that won't happen. But they did give us some information on some funding opportunities that we can go out and maybe seek some funds. So stay tuned for more information on these items. They gave us about 6 priorities that if we want to break it up, we can break it up into multiple projects. If we were able to, get some, best case scenario, full funding, from a different one location or another, we could accomplish everything all at once, but more than likely we'll be looking at a phased approach to doing all of this. So there'll be more information to come. We clearly haven't, signed anything. Nothing's really been engineered or designed or anything like that. But preliminarily, we've got some work to do with regard to our physical plant. I will also say that let me just get into the financials, I guess, and then we'll kind of go through some of that. Our total operating cash for January 31st was just over $100,000. That represents 3.5 days of operating expenses. Our accounts receivable was $4,097,531. That was down about $287,542. We had some challenges at the end of December with getting some of our statements out, and then so those got out, or insurance is billed. Those got out. That's pretty much the main reason for the significant decline in AR, combined with a slightly less amount of total gross revenue. So revenue was down, AR goes down, but a couple factors there. Our unbilled is getting close to our target. We're meeting our target with actual unbilled at 5.6, but that was up about a day compared to December. Third-party billing was down slightly and not meeting the KPI there. Billed for self-pay was, that should say minus 0.6. It was down to 6.7, which is meeting the KPI. But our total days is just slightly over our 50 days that we're shooting for. Accounts payable balance for January was at $1,150,827. That's down $477,000 compared to December. A couple things contributed to that. One is that we did receive some incentive payments through Medicaid, which gave us some more cash come in the door, allowed us to pay down some more bills. But we also have been working the last few months and totally revamping how we prioritize what we pay and who we pay and when we pay them. Just really keeping a close eye on that. And a couple of months ago, we were getting a lot of phone calls from vendors. We need paid, this kind of thing. And our goal is to get this down under $1 million, because we spend about $1 million a month, and so this gets us to where we're, if we get it under $1 million, we should be in that neighborhood of taking care of what we're doing as we're doing it, you know, that sort of thing. So we're moving in the right direction there. I think we've got a good process and plan in place, and so we should continue to see that number improve, I hope. Gross patient revenue was $2,284,312. Like I said earlier, it was a decrease of about $196, almost $197,000 compared to December. Our contractuals less bad debt was about almost 62%. Our net patient revenue was $807,000, which was a decrease of about $40,000. Our accounts written off to the collection agency totaled $173,898 in January. We didn't write very much off in December, and so that was about $125,000 increase versus December. Charity care, we haven't had a lot of charity care, but that was $464 in January. Our operating expenses, not including salaries, benefits, and depreciation for January, is $653,000, and that decreased about $80,000 compared to December. Salaries and wages for January were $555,359, which was also a decrease of almost $28,000. And then our net operating loss for January was $11,564, but when we add in non-operating revenue like sales tax and some other things, we were up to net income of $102,000. Compared to our budget, we're still running under budget, but mind you, our budget includes a cost report settlement that we actually did receive in February, the beginning of February. And so next month's financials will reflect that.
Which was a little short.
It was a little short. I was going to get to that. Our cost report settlement was anticipated to be around $710,000, and it came in at $565,000. We returned that back to our auditors to say, hey, is this what happened? You know, and they just today, you haven't seen it yet. This afternoon, I got an email back from between our auditors and Novitas. Novitas is Medicare. That Novitas acknowledged that they've made an error and they'd be getting that corrected. So we should be seeing that additional 180, whatever. I didn't do the math, but we should be seeing that before long. So that's kind of what the budget looks like, but when we compare this year to last year, year to date, our $118,000 loss, last year we had a $119,000 gain, but we're still, well, that kind of put us, the timing of that cost report settlement kind of put us to where we're not tracking as well as last year, but I think by next year we'll see that, or next month we'll see that number catch up. We'll also say there was another approximately $95,000 that we were anticipating in January that also didn't hit until the first week of February. So that made a difference as well when we reported for January 31st. Kind of significant financial activities or some outliers maybe. Our non-operating revenue was the highest it's been all year at $658,000. We did have our, what we would have normally, with the exception of $95,000 I just mentioned, we did have our quarterly shop payment come in. We also had a provider incentive payment that doesn't come in quarterly, but it came in January. And so that was $365,000. The other thing that was significant was other operating revenue, and that was with the 340B prescription drug program. And we had over $155,000, and then that was mostly due to getting some things cleaned up with Jennifer Nichols and her clinics, her ordering those prescription drugs on that program. So getting that cleaned up was really big, and made quite a difference in our January financials. Urgent care had its best revenue month in January. Senior Life Solutions had its best month so far. It continues to increase in gross and net revenue, so that's good. I mentioned that the downtown clinic had all that 340B revenue. There were also additional 340B expenses related to that. So, however, take that out of the equation, and the downtown clinic had its second best performing month all year from an expense standpoint. So we've had a lot of areas that are doing what they can to cut costs where they don't need costs, and prioritize spending when we need to, and that sort of thing. So it was notable in the downtown clinic. Surgery also had a very low expense month. Our non-revenue department expenses, so that's maintenance, housekeeping, billing, all the places that don't have claims going out for their services, continues to be under budget, and that was about $414,000, and we budget about $495,000 a month for those departments. But they've been under budget all year, except for the month we replaced the roof, and so everything is coming out good from our expense management standpoint. Talked about the cost report settlement already. So you can kind of see our 6-month and year-to-year comparisons in there. You can see our other expenses as well. Let's see. I think all in all, we are tracking, with what we know is going to come in, and with what our historical performance has been. We're tracking to meet our budget goals. We're tracking to, improve over last year. So I'm happy to field any questions. One thing, I'm going to piggyback a little bit on what Candace said regarding our billing contractor. We are anticipating that the new billing company, we're not banking on it, but based on their experience in other hospitals in our area, the transition from TrueBridge to this company resulted in a 10% improvement in cash flow. Like I said, we're not banking on that, but we are anticipating that we could experience that same improvement in cash flow, and we continue to work to try and get everything in order, so that when we do get the green light to make that transition, that we're prepared to do so.
Those accounts that are 150 days and older, is that due to billing or people just not paying?
Yes.
Or insurance companies can hold that stuff up and not process it, and it's a combination of a lot of those things. When we gave TrueBridge notice that we were wanting out of the contract, that we were leaving, it was amazing how many accounts just came out of the closet that hadn't been worked, and we're like, where have these been? So yeah, it makes it look like we're not doing our job.
It does.
It really does. That's why we want away from this company, because they do us no favors as far as public perception and our billing. It's killing us.
Well, and there were protections in that contract for the billing for TrueBridge that we're going to make sure that in this next contract with this next company that those protections are for us, because they're operating off of that company and the next company. They're operating off of a percentage of collections. So if they don't collect, they don't get paid. But it's got to be built into there that there's a performance expectation, more so than just they don't need money as much as we need money, because that model is not working for us. But if they don't have the same need for that cash flow that we need for that cash flow, then there's no incentive in there for them to collect it.
I think the high dollar accounts and those little piddly accounts, they just don't work.
So I will say that people will have been either will have just recently noticed, or will be noticing, a change in our statements. Our statements have had not very much detail when they've gone out, but we've gone to a detailed statement so people can, hopefully look at their statement and tell what it is that the statement is for. And of course, our staff are always available to field those phone calls and help explain the bills as well. But hopefully that's going to clean up some confusion regarding folks in their hospital billing. So we're even with the even with our dissatisfaction with our current contractor, we're continuing to try to make sure we're putting things in place, not just waiting on that June deadline of when we're going to switch to start, not start, but continue to improve our ability to meet our patients and their whoever's paying their bills, their expectations. So it's an ongoing effort.
Okay. Anything else, Kelly? Move to the medical staff executive committee.
You want me to do that?
Yeah, if you
All
would.
right. Dr. Burke wasn't able to be here tonight. The following items from 5B1 and 5B2 are all reappointments to the medical staff. They will be approved or disapproved by one vote unless any member desires to have a separate vote on any or all of the following items. Agenda and minutes review. No changes to that, to the minutes. B, credentialing committee. Reappointment to courtesy staff, Dr. Brenda Krishnan, MD, telemedicine hospitalist. And reappointment to courtesy staff, Dr. Benjamin Love, MD, pathology.
Okay. There is a motion. Is there a second?
Have we had a motion?
Can I do both at one time, or do I have to separate them out?
No, according to the agenda, it's for both.
Okay. Reappointment to courtesy staff, Brenda Christian, MD, telemed hospitalist, and reappointment to courtesy staff, Benjamin Love, MD, pathology.
Second. Okay. Now we have a motion. Who's the second? Motion by Dr. Simon, second by Greg.
Simon?
Yes.
Mossberg?
Yes.
Brown?
Yes.
Martin?
Yes.
Bowman?
Yes.
Okay, next item is improvement to patient care.
All right, so we have the contract review. We have 11 contracts, all were compliant. Next thing is the periodic review summary report. And if you'll remember, those are all policies and procedures that have been reviewed, or new policies and procedures. And on the agenda for that is B, discussion and action to approve, disapprove the revisions report. Are all the separate votes? I can't remember.
It's got under A that all can be approved
Okay.
by one vote.
And then C, approval, disapproval of the 3-hour glucose tolerance test procedure. Then we have some changes to the routine paid time off buyback procedure. That's a procedure that we allow employees, if they max out on their PTO, then they just go into a point where they start losing that benefit. So basically they're not accruing time off. Sometimes it can be because we're short-staffed, sometimes they just don't want to take off. So we have a policy in place with some parameters. We want people to take off to recharge their batteries. But we also have some measures in place that if they're maxed out on their PTO, they are allowed to buy some of that back, so it buys it down, so they get the benefit of taking cash in hand, and then that allows them to then again keep accruing.
And they don't have to max out. So if something
No, they
comes
don't.
up in their family and they've got a family emergency and they need some cash, they can
They're short on cash.
they can use this policy to buy back for times like that as well.
It's been well received. We've had employees use that, so it's kind of a good thing. We can kind of help them out in a time of need. And then E is the approval, disapproval of the radiology hours of operation. That was just something that was missing from their policy and procedure book and added.
Is
Any
our,
questions?
is our buyback policy just pretty standard, a standard policy that other places use, or is it?
I'd say it's kind of unique.
I think we're kind of unique. I think a lot of places, when they do a buyback policy, they make that buyback at a lesser percentage than what was actually earned. And so ours is, and this is a second coming of this policy, like this is a revision. When we started it, it was a percentage of whatever that cash value would be. Now it's 100% of that cash value. Prior, it was they were only able to ask for it during certain months of the year, and we've changed that to where they can ask at any time during the year. They can ask for the buyback once a month, but we did put limits on it, $1,000 at a time or 40 hours, whichever is the most there. And but they can. It's a lot more liberal than it was before, and it's a lot more fair to what they've actually earned.
But so like if a bunch of people decided to cash out a bunch of buyback at one time, are we financially prepared to?
We are.
Okay.
We looked at that, and based on what we kind of have is, some people do use their PTO,
Okay.
and some people just aren't able. But based on our PTO balance that we have and the limits that we put into place with that $1,000 max, we won't ever cash out more than $1,000 on any employee at one time. That parameter being in place allows us to be able to cash flow it.
Okay.
And if you notice on D, it says the organization may suspend the routine PTO buyback policy at any time due to financial constraints.
Okay.
So if we are in a position that we just can't do it, we're not obligated
Okay.
to do that.
Any other questions?
And I will just add on that, since we've started that, people have been using the buyback, but our payroll it's gone down.
Okay.
Okay, items 6B through E can be voted on one motion. Do I have a motion?
I make a motion to approve items 6B through E.
Second.
Okay, there's a motion and a second.
Mossberg? Yes. Brown?
Yes.
Martin?
Yes.
Bowman?
Yes.
Simon?
Yes.
That motion is approved. Share convalescent.
So there is no shared convalescent home anymore, but we do still have some financial items that we're wrapping up. We did, everything closed in January, which I know we reported that at the January meeting. We do still have some Medicare and insurance dollars that will be coming in for services provided prior to December 31st. But other than that, we're no longer generating revenue from the nursing home. The expenses that are coming in are also from prior to December 31st. So we're seeing cash transactions, we're paying bills, or we're receiving payments for services provided. But these numbers really, they're not indicative of an operating facility, clearly. The accounts receivable balance, I will tell you that when we went back through that and we have sent notices out that they'll have till March 15th to either pay in full or make arrangements for any unpaid balances. And in looking back through that, this doesn't look like it's been trued up in a while. The $967,000 that's in the report needs to be trued up with, and we need to get some stuff sent to bad debt. But our collectible portion looks to be closer to around 300,000. And so that's, we do anticipate that that cash should be, collected. If we have to use a collection agency, we'll have some fees associated with that. But our goal is to get all of that cleaned up to where everything that is collectible is collected. Yeah.
Any questions? Okay. Homestead.
Homestead is operating, and they're doing just a pretty, steady job, what they do over there. They, nothing really remarkable up or down or anything like that. We have seen what we anticipated in an increase in meal revenue as all the meals are being provided out of the homestead kitchen. The occupancy has continued to grow a little bit here and there, and so our inpatient revenue that's listed there for January 2025 was 72,338. Some of that is timing, because the homestead, we do that on a cash basis. So when the cash comes in, that's when we count it as revenue. The homestead has one account that is unpaid balance, just one, and we're working on getting that taken care of. It's not a big amount of money. But so the homestead had total revenue of $90,209. Of course, we also moved all of our dietary staff that in order to be able to provide all of the meal services, we had an increase in dietary wages and benefits over there. And so their total operating expenses were $85,444 with a net income of $4,765. I didn't point it out when we were talking about hospital expenses, but January was the month where we started the 75%. I think you guys approved it back in October, where we paid for 75% of the premiums for their health insurance. And so that started in January. And like I said, it didn't, we were able to, as we anticipated back in October, we were able to sustain that expense without issue. Same with the homestead, that got added to their benefit total as well. And we did have an increase in enrollment in our health insurance plan, which ultimately is good for us as an organization. That's the homestead expenses, income statement.
Anything from the foundation?
I do not have anything for the foundation.
Okay. Greg, anything from the city?
Other than the routine business, we'll talk about a little bit about the Alva EMS. I've spent multiple hours visiting with those folks. They are on a PIP plan. From what I found out, in visiting with them, of course I haven't visited with Candace yet, but from what I understand on my side, that things are getting better. Now, we'll have that conversation. They are dealing with this month to month. We're going to do something. We're going to fix the Alva EMS because I'm frustrated that EMS and the hospital are doing this instead of working together. And it's my mission to see that they start working together. I don't know what we do to make that happen. I hope it's getting better. But it's on a month-to-month deal at this point. And really, it's the Alva EMS has been the big deal. I don't know what else to say about it. There's some things I can't say about it. But I guess that's
Yeah. For us, we just, on behalf of the hospital, we want what's best for our patients. We're, at the end of the day, if Kayla Simon is laying in that ER and we need to get her out of here, that is our mission, that is our goal. We want what's best for each and every patient. And having to pull from other communities their resources to get our patients out of here is not ideal. And in fact, that's why we have that helicopter setting out back, is because we had trouble getting patients out of here. So we want what's best for the patients as well, and we don't care who runs the service. In the end, at the end of the day, it's that we have the service available that we need for our patients.
I don't know what else to say. I mean,
It's a work in
I
progress.
want that, exactly what you said. So I know I'm spending extra hours visiting with these folks, making sure they do the plan, the PIP that they have to do. I mean, they're on notice that you can't pick and choose what you want to do and what you want to accomplish. And I think they have for a little bit, and it's not that way anymore. And month to month, we'll see next month what happens. I was pleasantly pleased with the first month, seeing what they produced. It's 1 month, but it's not a month-to-month deal. We've got to do it every month, every year, all the time. So hopefully those folks will figure out that it's a full-time gig and you can't just do it 1 month and then ignore it. I personally believe they're trying super hard to do it, but we'll see. I really don't know what else to say on that front.
Any other business needs to be brought up to the group? Hearing none, I think we can adjourn.
You too. Thank you.